Actually, instead of questions at the end of session, we have taken the panel. So I thank all the 4 speakers from metformin to sulfonylurea, DPP4, SGLT2, all are included. All prominent OADs we have taken in this session. So very interesting session is the panel discussion. I invite Professor Lalit Meher, my teacher and part of the NUCD team, to join us as moderator. And I think Dr. Kota is there in other session. Stuti, you just put the OAD session. Yeah. OAD session slides. Yeah, Professor Meher has joined. Sir, welcome, sir. So Professor Meher and me will be moderating this session, and I see Professor Das is there, and all our panelists. Dr. Jubin.
OAD people don't go away. They are.
Yeah, Dr. Jubin and Dr. Manoj, Dr. Nilanjan, all are here, and we'll be trying to save some time, as all of you know. We are running a little late, and very interesting sessions. I know Professor Das will support me, and we have to keep time in the
two questions to each. Two questions to each. There is one question already on the chat box. If Lalit says a question in chat box,
we'll take that, sir. You have seen our preparation, so I request Dr. Schwein also to join the panel. Sir has very nicely chaired and moderated the whole interesting session.
Great jobs.
Yeah. Dr. Schwein has done a great job. And let us answer the questions. I request Dr. Kanungo also to stay back, so that very quickly we can answer the questions and give a clear message in the field of OAD. I request Professor Meher to start the panel discussion from Professor Das.
So my hearty thanks to Dr. Kanungo, Professor Das, Professor Jayant Panda, that you have made me a part of this wonderful webinar. So to initiate the discussion, I'll first ask a question to Professor Das, just to a simple one. How to decide to intensify the oral drugs? That means you go from 1 to 2 drugs, then to 3 drugs, and like that.
I think this is a very, very significant question, because initiation and intensification are the bottom line of any diabetic treatment. Now, intensification is decided when, as an optimal dose for 2/3 weeks, there is no desired result. And if it is not there, we intensify the treatment. We do not wait for the 3-monthly HbA1c ordinarily. We wait for the blood sugar estimations at the end of 2 or 3 weeks. And then if the desired result is not there, we keep on adding the drug. But adding beyond 3 drugs is of no use.
So far as metformin is concerned, actually, at least we need 4 weeks to get some result. Then we have to again intensify the doses also.
Yeah.
So
yeah, it is the. I think, Lalit, there is no hard and fast rule. It's by experience. So you must know that how long this drug take to produce the action. So suppose you have started a patient on the glitazone, you have to wait a little longer, because the pioglitazone, etc., used to take about 4 days to produce their first effect. So depending on the drug, the sulfonylurea drugs, you can change over after 1 week. Metformin takes about 3 weeks max to produce its results, depending on that.
Thank you, sir.
Next question is for Dr. Jubin Jacob, and we want to ask a very important aspect. Which group of drug you prefer as a first and second add-on? We know that we ask for the lifestyle modification, we ask for metformin, but as per the present guideline, as the first add-on, second add-on, which group of drug you will prefer?
You've asked me a very difficult question. I don't think the ADA, EASD, anyone has come to any conclusion about this. So I think we will go with what they say. We will individualize for each patient, which is the second drug. So if it is somebody who is overweight, who has a history of heart disease, or who has a family history of heart disease, I would definitely keep SGLT2 as the second drug. if it is an older patient who has a risk of hypoglycemia, I mean, who stays alone at home and a hypoglycemic episode may not be well managed by them, I would definitely consider DPP-4 as my second line drug. So I think the ADA EASD has not been brave enough to tell us that. And I think we have to individualize this decision. But I think sulfonylureas are not going to go anywhere, though they seem to be lower down on the list. But in terms of glycemic efficacy, in terms of the cost, they are going to stay. And among sulfonylureas, glimepiride is going to definitely stay.
I mean, it is customized. I think, Jayant, answer to your question is exactly what Jubin has said. The ADA, EASD, even our RSDA guideline has given broad guidance, but we cannot. They are not pinpointed the drug. If the, as rightly said by Jubin, CVD risk factors or the atherosclerotic risk factors are dominating, one should go for an SGLT2. If the patient has got more of atherosclerosis, less of risk factors, they also say injectable GLP-1 RA, but oral will be coming now. Now, depending on the other drugs, it depends what you have. And as rightly said, the sulfonylureas are going to stay because of their immense benefit at a very, very low cost. I know that's very important. And between the glimepiride, glyclazide, glimepiride is much cheaper.
So very well shared, sir. Depending on the comorbidities, the cardiorenal issues, the atherosclerotic cardiovascular disease, the obesity, we take up the drug, and as you told, we can have oral GLP-1 also, and the list will be broadened. Then we'll go to the next question, Professor Meher.
Question to Dr. Manoj Chawla, which is the exact indication of starting a DPP-4? That means you initiate with the DPP-4.
Right. So let me just lighten this discussion, and as Dr. Professor Das was speaking for glyphosins and Dr. Jubin was speaking on SUs. I did, of course, speak on metformin in pre-diabetes. And in Jubin's style of presentation, let me remind them that whoever may be James Bond, metformin is still the money penny, and you both are going to require this money penny for all the action out there.
Absolutely.
Coming back to the question here as to where one would use DPP-4, I think the advantage of DPP-4s largely are the fact that they're extremely safe drugs. So post metformin or besides metformin, if there have been any group of drugs which are very, very safe to use, non-hypoglycemic, predictable response, least side effects, safety in the elderly population, I think that's what DPP-4s are. So DPP-4 kind of fits into multiple positions. Very often today, if the person does not have any cardiac comorbidity or any kidney comorbidity or compulsions, along with metformin, you may consider the use of a DPP-4 right from the beginning. If the HbA1c is not extremely high and you are afraid of hypoglycemia, I think a DPP-4 with metformin would be started right very in the beginning itself, as we saw the data from the initial Virtue and many other studies. So DPP-4 fits into multiple places. It's a drug which, as I said, to its advantage, you have that caption that use it and prescribe it and forget it. It's a least headache drug.
Yeah. And also addressing Manoj, addressing 5 of the ominous octet, at least 5 aspects of the ominous octet.
Yeah, very rightly told. We take it as a very safe drug. Feel it and forget it, Hero Honda style. And with this, I'll go to Nilanjan with a little difficult task. When do you decide not to go for a DPP-4 inhibitor?
Well, that's really difficult. I decide not to go for a DPP-4 inhibitor when there is a history of pancreatitis of any sort.
Absolutely.
Irrespective of the etiology, even if it be a gallstone pancreatitis, which has adequately been taken care of to avoid any legal problems, I do not initiate on a DPP-4 inhibitor. But I may say in my 10, 12 years of experience with DPP-4 inhibitors, I have found at least 5 or 6 patients who had GI intolerance, peculiarly enough, GI intolerance in the form of nausea or diarrhea, which probably could be attributed to DPP-4 inhibitors. In those cases, I had to, stop because of GI, make some vague GI tolerance or intolerance. I remember of 2 patients. They had no problems. She had no problems with AGI, metformin. But the moment I gave first vildagliptin, then changed over to sitagliptin, the patient had that problem. That's one thing. And of course, now in the present scenario, if I get a patient who is having diabetes with a cardiovascular risk or an established cardiovascular disease, or who is obese, probably I would be with albuminuria, I would be inclined to maybe prefer an SGLT2 inhibitor. Sometimes maybe I co-prescribe an SGLT2 inhibitor or a DPP4 inhibitor, or sometimes an SGLT2 inhibitor prescription gets my preference over a DPP4 in addition to metformin, probably.
Yeah, very nicely told. Dr. Chawla.
And I'm actually going back to Professor Sen Gupta, and I also see that Dr. Manas has also asked that question. And I think Professor Sen Gupta was clear in showing the data for vildagliptin once daily, but with a lot of disclaimers and still, wanted information. The concern, Dr. Sen Gupta, that remains for many of us is the history with the hepatic enzymes disruption in the 100 milligram once daily. Now, what has happened is a lot of companies trying to show they've done their pharmacokinetic data, as you showed, even from the Novartis study. And in terms of side effects, they're just saying no serious side effects and well tolerated. But there is no documentation, again, of the hepatic enzymes and what's really happening. The question is, where really is a pressing need for once daily vildagliptin as compared to what we saw with twice daily, very often used with metformin. So again, there's no issue about using it in that 100 milligram, especially when this question has remained. And this is only India specific. It's not that the Novartis itself has launched the 100 milligram extended release or modified release anywhere outside that. So that remains, somewhere, some skepticism, some doubts that still remains about the lack of data and clarity. Your thoughts there?
Yeah. That's what I said. It's basically, it has been launched in India, even by the innovator and as well as by the branded generic companies, simply on market demand and to do something new. So that's it. But having said that, that's what we are also looking in our own departmental study. Of course, it will take 6 months to 8 months for us to acquire the data and then analyze and publish it. But initial results do show that there is not much difference between liver enzymes. Even in my practice, when I prescribe a single daily dose of 100 milligram vildagliptin, I make it a point to repeat a liver function test at the first visit. And I haven't found it as yet one single instance where I had to stop it because of elevation of liver enzymes. That's it, but it's an innovation. We were managing it when it was not available, but always on a long-term basis. That also, if I take myself as a patient, as I'm a busy doctor and like a busy executive, if we have to take 2 tablets, one in the morning before we are going out to work, rather than you take 1 tablet, and if you there would be less chance of missing it. That's, I think, the only advantage in that case.
Yeah. Very rightly told.
Jayant, one more issue is that, some of the drugs, when combined with vildagliptin, had to be given once a day. And they are giving twice a day was an issue. Am I correct?
Yeah, absolutely, sir.
So combination therapy, that's why they brought it in. And US FDA did not approve. They did not go back to US FDA after that. It's a good rebuff to them. They are not planning to go there anymore. So I think that is the issue, that we put a combined drug with XYZ product, which is given once a day. 100 milligram becomes handy. That is the only issue, Manoj, which has driven this drug to be 100 milligram.
Yeah, I think
how the PKPD of this 100 milligram vildagliptin appeals you, sir, Professor Das?
I think I cannot say the PKPD studies offhand, Lalit, but I'm telling you that, see, I'll give an example. Say remogliflozin. They want to give it once a day along with metformin and vildagliptin, the triple combination. They're looking for a drug where metformin, we have single daily dose, 850,000, and we also have remogliflozin daily dose. And nowadays, it used to be twice. So they wanted to have a drug which can give them a combination therapy with 100 milligram of vildagliptin instead of giving it twice a day. That was the type of logic on which they brought it in. The Novartis remains the innovator for the vildagliptin, the Galvus, and they brought Galvus 100 only for that reason. And also the people who are getting Galvus twice a day, if it is given once a day, they found that it is working. I think Niranjan, you must have gone through the PKPD studies. Can you tell us?
Yeah. Basically, largely speaking, I didn't make it data heavy. We had the detailed slides also at my disposal, which I think Novartis and other companies can provide if interested. They have largely shown to be equivalent. The PKPD studies have largely shown to be equivalent, and so far as the liver enzymes is concerned, but then always proof of the pudding is in eating, means they may not translate into in a real life scenario. So that's what some skepticism is there, but initial results are quite encouraging. That's at least from my own very limited clinical practice, I can say the initial results are not at all that discouraging.
Yeah, very, very well told. And because we are just picked up the molecule, I think in due course we'll see the liver function, we'll see the different aspects of the drug and see whether it will stand the test of time or not. So with this, my question again to Dr. Jubin Jacob, from DPP-4 controversies, we are coming to SGLT2, and this is the $1 million question where all of us are baffling around. In your practice, you prefer a biosimilar or originator dapagliflozin?
Again, the question.
And why?
So I have, absolutely no hassles in prescribing generic prescriptions. So usually I write dapagliflozin. If I know the patient can afford, I definitely write. In our hospital, the practice is if you write the generic prescription, they will give the cheapest molecule that is available in the pharmacy. The only time you are allowed to write a brand name is when it is the innovator molecule. So if I do want to write a brand name, I write Forxiga. So these are for patients who can afford it. So they ask me the same question. These are Punjabi patients. I tell them, are you going to, you need some alcohol in the evening. Are you going to drink Desi Daru? Are you going to drink Royal Stag? Or are you going to buy a Scotch whiskey? If you're the type who's going to buy a Scotch whiskey, you should insist on the brand because that is what the innovator is. So Punjabis are generally brand conscious. So if I give one brother a generic preparation and the other one, I give them the original, the other one will get upset with me. Why did you give me the cheap one? So you have to, both these options are there and you have to decide which patient will get which option.
Yes, sir. Very, very well taken. And what we see practically, the efficacy, I think Dr. Kanungo is worried about time. I understand. Sir, are you on mute, sir? Dr. Kanungo.
In addition to Jubin's opinion, I was also writing a lot of originator dapagliflozin. When the brand came, I have much more opportunity to write dapagliflozin, and I have given more than 10,000 prescriptions, and result is excellent.
Yeah.
There is nothing
like affordable.
If you select brand of the generic, then you get the right result. So there is no comparison. Both are almost same.
Sir, actually, like the affordable DPP-4, the teneligliptin made crores and crores of prescription worldwide, became the most prescribed DPP-4 in the world. Similarly, in India, anything becomes affordable because our people pay from their pocket, and if the efficacy is more or less same, we can go for a generic or more affordable or a biosimilar brand, which will be which can be given to people at large. So,
and I have a small story to say. When we did not have Teneli, Professor Lele of Bombay fame once told me, Ashok, can you manufacture DPP-4 inhibitor like the Africans manufactured the anti-HIV drugs? The need was so great. Yes. And DPP-4 inhibitors or SGLT2 drugs have become the standard of therapy, no doubt about it. Now, therefore, once it is available, Jayant,
Sure.
I mean, it is. One is free to prescribe the brand conscious people like Jubin's the Sikh gentlemen can take their brand, and the people who cannot afford can take. But the benefits are the same because they have been compared. There are two arguments with the innovators make. Number one is that this brand has not undergone the clinical trial. This particular generation brand is called generation brand. Generication brand has not gone. And number two, they say that we are longer in the field. But the number of prescriptions, as just now Alok said, 10,000 prescriptions in about 2020 October onwards is a great number. So I think there is nothing much to choose, and especially for the oral biosimilars. So they are biosimilars. They may not be bio better, but they are bioequal.
Thank you, sir.
Actually, we have got 3 glipogins, say EMPA, DAPA, and CANA. How do we choose which drug to use?
This is a very, very intelligent question. I think Lalit, same question Manoranjan also had asked. Manoranjan here.
Yeah. Actually, these questions we had for the panel, and also our delegates and other faculties have asked.
You see, I'll make a very candid presentation. Number one, that whom do you want to love? Jesus Christ, Lord Vishnu, Lord Krishna. You Lord whomever you want, the benefits are the same. It has been said that the effect of SGLT2 are a class effect. I am talking about the opinion of the experts who Sundar Mudaliar and his colleagues, because these questions are asked Lalit again and again and again. There is a class effect. But there is some subtle things I'll point out. Number one, the between DAPA and EMPA, it has been said that DAPA has a little bit more effect on the preventing heart failure. EMPA has some effect for production of longer life. CANA has some effect for the renal friendliness. So there are some subtle differences between the three, but more or less, it has been said today that between DAPA and EMPA, there is nothing much to choose, except DAPA has shown the cardiac heart failure benefit little better than the EMPA. But EMPA at the same breath has shown survival benefit. And so there is nothing much to choose between the two. And the canagliflozin has shown something to do with the renal benefit. And maybe that Credence claimed they can give it up to 25 eGFR, which has been negated by many people, but let us accept as it is. So the bottom line, that is a class effect of all the benefits which is found in all the things. But the drug which comes fast, Rolls Roast, they stay there for a longer time because people start prescribing it. But the second drug, if it becomes cheaper, becomes better, people also take it up.
Yeah, I think Professor Das very nicely covered this topic, and the next topic was also based on the similar theme, which was we intended to ask Nilanjan which SGLT2 inhibitor has evidence of cardiorenal protection, because the CANA, DAPA, EMPA, I think it's already covered well. Anything more you will add, Nilanjan?
Between the three, of course, we have the most first and the best data with EMPA-REC outcome trial. That's why empagliflozin probably has taken sort of a lead in cardiovascular protection. We have heart failure data to come with dapagliflozin, and we have the Credence data too. So again, over and above, there's little to choose between them. You can do a hair splitting. For secondary prevention, you would choose empagliflozin. For maybe primary prevention with multiple risk factors or not established heart disease, you would think of canagliflozin or dapagliflozin. For heart failure, we would prefer either DAPA or EMPA, since till now, we do not have a dedicated heart failure outcome trial with canagliflozin and so on and so forth. But as Professor Ashok Kumar Das has rightly pointed out, by and large, all these point to the same direction. Maybe artigliflozin didn't show that much of promise. Even that may be a play of chance, statistical chance, we don't know. But all of them, the data with all the SGLT2 inhibitors point towards the same direction, and conceptually you can choose any one of them as who may be your God to save you, as very nicely elucidated by Professor Ashok Kumar Das.
If I add here, we have another SGLT2 inhibitor, remogliflozin, which has been launched, and we don't have much studies associated with that. So what is your opinion regarding?
Yeah, that's a very, very interesting question. Now that generic dapagliflozin is available, I use very little of remogliflozin. But if you have to use remogliflozin for glycemic control, then you can use it because you have the data, whatever little it is. But if you want to give an SGLT2 inhibitor for pleiotropic cardiorenal benefits, choose one that has a data behind them. That is empagliflozin, canagliflozin, or dapagliflozin, and not probably empagliflozin. And now the cost of therapy, cost differential between dapagliflozin generic and empagliflozin is not much. In fact, dapagliflozin 10 milligram may cost less than 2 tablets of empagliflozin daily. So I think for pleiotropic benefits, where that is kept in mind, I think you choose one which has published data behind them.
Fine. It's a very clear note. Thank you, Nilanjan. Professor Meher.
So metformin is widely accepted as one of the important drugs for preventing diabetes, or that means in pre-diabetes.
So we can
given the benefit of SGLT2 inhibitor, has it got any place in the management of pre-diabetes?
Yeah, Manoj Chawla.
Chawla?
Right. So we don't really have data specifically in pre-diabetes, but as we did see some amount of data for DAPA, both in the DAPA CKD and DAPA HF, where you had patients without diabetes also, where this drug was used. And besides the benefits that we saw there in the reduction of renal endpoints as well as the cardiac endpoints, they did show reduced new occurrence of new onset diabetes with dapagliflozin in that subset of non-diabetic patients. So that's the data that we have for DAPA. Having said that, is this a drug which is approved for patients with pre-diabetes? Not yet. In fact, most drugs for pre-diabetes will come with a caution. As I said in that conversation and interview with Dr. Kanungo, that the ADA EST today talks only about metformin in those 3 scenarios of age less than 60, BMI less than 35. And when I say 35, it's for Caucasians. I would say for Indians, it should be probably 32 or even 30. And previous history of GDM. Those are clear indicators where you should use metformin. They've tried liraglutide. They've tried voglibose in some studies, all of them with limited results. One drug which showed failure was nataglinide. So SGLT2s do make sense in terms of the data they have shown, but are they still recommended for use in pre-diabetes? I think that's a bit too early for us to jump to.
Thanks.
Thank you. Thank you, Manoj. And it's time. We have to brief and very quickly we'll sum up. The next question is for Jubin again. You have been using the different drugs. What is your expert opinion on the oral fixed drug combinations?
I think, we have used fixed drug combination for the last 20 years. For as long as practiced diabetology, we have used fixed drug combinations. And I think the world has also come to realize that fixed drug combinations are very useful in terms of improving compliance, in terms of improving outcomes. So I think now you are seeing, there was a time where triple drug combination was considered to be a no-go area. Somebody combining 3 drugs was thought to be something completely unscientific. But now you can see they are going to use triple drug in the FDA has approved triple drug combination. So I think fixed dose combinations are very much part of practicing diabetes, especially to improve compliance and improve outcomes. But I think they should have some background information about pharmacology, bioavailability, and with that, I think we can safely use these drugs.
Yeah, very rightly told. And the Indian way of combining drugs has gone to now US FDA, and they have started combining fixed dose combinations. And because the pill burden comes down, as we discussed about the vildagliptin, the compliance definitely increases. I think the last question will take to Professor Ashok Das. Professor Das is here. I don't think so. We can end with the last question to Dr. Manoj Chawla. Beyond how many oral drugs one should change over to insulin?
So I think that's a difficult one.
Because it's in the Indian way, 1 drug, 2 drug, 3 drug, 4 drug, 5 drug, we see it goes on increasing. So what is the science?
Well, there's actually nothing wrong if you're going to be using different drugs with different pathophysiological mechanisms today. But having said that, you need to have your targets in mind. If your patient can achieve that target with 3, 4, or even 5 oral drugs, today we know that a lot of evidence for cardiorenal protection is seen more with some of the oral drugs and not necessarily the injectables. So you should have that in mind. If your patient is not reaching the target is the time that you really start conversing about insulin if you haven't spoken about it earlier, or the injectable therapies. But it's important that we don't keep dragging. I think it's important to keep having the conversation for tighter control. If it can be achieved with oral drugs, including multiple ones, it's fair. If you cannot, it's time to use a therapy which is going to have definite response in terms of glycemic reduction, and that's insulin. So having said that, it's not really right for us to kind of shun away or ostracize the multiple drugs today. If somebody is going to be on a combination of sulfonylurea, metformin, and a combination of DPP-4, SGLT2, and maybe a little alpha glucosidase here and there, and that's going to get our patients to 7% and around and below, I think it's absolutely fine.
Yeah, that's the clear message. Different mechanism, different pathologies, we have to titrate, and as soon as indicated, we should not hesitate to go for insulin as well. I request Professor Meher to conclude before we go to next session, because it's time that we should end this panel discussion here.
It was really a wonderful session, and it was a very treat to listen to all these stalwarts. They have done full justice to their topic. It was really wonderfully discussed about the modern sulfonylureas, the dapagliflozin, the 100 milligram vildagliptin sustained release, and the role of metformin. And again, once again, thanks to all the speakers. So we conclude this session now.
Thank you, sir.
Thank you, Professor Meher.